Okay, so we're making this quick video to review some quick and important facts about bowel programs. Again, it's really important for our patients with spinal cord injury. It can help them have, fewer unplanned bowel movements or accidents or incontinence. That can cause a lot of embarrassment and lack of confidence in work and social situations for when they leave here. Also, when they are here, it can eat a lot of therapy time up. And so we really want to be able to put them on a regular, consistent bowel program, also to help them prevent having significant constipation. Now, there's two different types of bowel injuries that you can have when you have spinal cord injury. The first and most common one is one that we call the reflexic bowel. So one where even if you can't feel your bowel movements, you actually still have reflexes that can trigger your bowel movements. And so those are the people that we use the rectal stimulation and the stimulant medications that we order for the patients. It's not for everyone, but it's for the large majority of them. And so the first part of this is just going to be quickly reviewing how to properly do a bowel program for somebody who has a reflexic bowel. The most important thing for that is you'll often see that they have a suppository ordered in the evenings. And it's very important that that suppository doesn't just get placed and left, but it has to be combined with digital stimulation or rectal stimulation. So this is a little picture to show what we're dealing with. We've got these intestines coming down to the rectum. This is where the stool will sit. And this part has to be digitally stimulated to make it take advantage of the reflexes that are there to help push that stool out with that suppository. So it's important to use a lot of lubricant, be gentle. Pushing or rotating the finger too roughly can irritate or tear the rectal lining, but it's very important to do still because it is what essentially relaxes and opens the anal sphincter. It straightens out the rectum, and then it really triggers, this word means the movement of the stool out from this wall. So from the time you start the stim, it really shouldn't take long for the stool to come out after you put the suppository in.
Rapid response 413.
I was just going to move on. And we can always edit that part out, kind of what you're saying. Okay. Now, we're going to go about how do you do a bowel care? So if I have a reflexive bowel, so one, make sure your hands are clean, that you are setting up and positioning. And positioning is very, very important. Sitting up, for anyone who can sit up, they should be sitting up. Gravity really is what moves everything down into the rectum in the first place. Make sure that your foot is on level, secure ground. Make sure if you don't sit on your sit up, you should at least be laying on your left side, and that's just the direction that the stool tends to move easier. Okay. So this is again reviewing what we went over a little earlier, inserting the suppository in, and then use a gloved and lubricated finger. Some patients may be able to use an assistive device to put it in themselves, but this is also something that will require education. So they may need a little help to learn how to do that. Until then, we need to help them with that. And then do the digital stimulation. And then first you're going to give them about 5 to 15 minutes for that suppository to work. If you notice any gas or some stools coming out, it's a sign that it's actually starting to work. And then to keep the stool coming, you need to stand there and repeat the digital rectal stimulation every 5 to 10 minutes as needed until all that stool is out. And it can be very impressive for some of our patients how much stool comes out. So be patient and make sure it's all out. And then recognizing when are we done. So to make sure that the rectum is completely empty, it's important to do that final check with, again, a lubricated and gloved finger to make sure that no stool has come out after 2 dig stims, at least 10 minutes apart. Sometimes you'll notice some mucus coming out, and that's another sign that you may be done. And then you can also see that rectum, it'll shrink a little bit. It'll look a little bit more closed around that stimulating finger. And those are all signs that you have completed the reflexive bowel program. And this, again, is going to be the most common bowel injury in a lot of our patients. And then help the patient get cleaned up and ready for bed. I'll pause there, and I'm going to look at the video, or I think maybe you can demonstrate an version of that. And then we'll do the reflexive. Sure. Okay.
So I'm going to demonstrate how this should look. I will say, and I will repeat this later, and all of you that have been in orientation with me know that there's something wrong with this picture, in my opinion, and that is that the patient is laying down and not sitting up in a shower chair. They really, really need to be up for the bowel program to be most effective. You're always going to obviously want to wear gloves. I will always double glove when I'm doing a bowel program, just because I don't want to take a chance that the glove will break while I am in the middle of stimulating the bowel. Of course, you should always have discussed with the patient what you're going to do before you start. They should know when you're putting in the suppository that the suppository is not the complete bowel program, that there is another step, and that step includes getting up, going into the restroom, and that there will be some digital stimulation with a finger. I always use my dominant hand if I can, just because I have more control that way and it's more comfortable for me. There are occasions, depending on the situation, where I do occasionally have to use my non-dominant hand, but whenever possible, I use my dominant hand. Apply lubrication to your finger. And always, always, always let the patient know what you're doing. Inform them before you're about to start so that they're not surprised. While some of them don't have sensation, most of them can still feel some pressure and know what you're doing. So always, always explain before you start. Hello, Mr. Patient, I'm Julie. We've already talked about this. You've had your suppository. I gave it to you about 20 minutes ago. We're up, we're in the bathroom. I'm gonna go ahead and stimulate your rectum with a finger. So I'm gonna go ahead and start right now. And then you insert your finger, and starting by pushing towards the belly button, move your finger in a circular motion, trying to touch all sides of the rectal wall. Remove your finger. Generally, at this point, you will have some stool pass. Sometimes it is just gas. Wait at least 5 minutes. You can try to make conversation. If the patient is stable, you can tidy up the bed, tidy up the bathroom. And then you're going to repeat the process after at least 5 minutes. Generally, this will require, well, you're going to change a glove because the first one you used is going to be dirty. And then you repeat the process. Again, applying plenty of lubrication to your finger, letting the patient know, okay, we're going to go ahead and do our second stim. Then again, you enter. Circular motion, stimulating all sides of the rectal wall. Generally, we've always said 3 to 5 times is the amount of times you want to stimulate. However, we do want to try and make sure we get as much of the stool out as possible. You will know that you are at the end when your finger comes out fairly clean. Obviously, it's not going to be completely clean because of where it just was, but you will notice a difference and you won't see stool. You'll see primarily lubrication on your finger. Does that sound okay?
Yeah, thank you. And the last part to wrap up, I did just want to provide a little bit of information on what's not as common, but is actually an important bowel problem for us to be aware of, and that's called a bowel injury affecting a lot of the reflexes. So those people who can't take advantage of the suppositories and the colace and the senas and the Miralaxes, some people we have to be a little bit more creative of. That's what happens when the spinal cord kind of ends around where you start getting closer to the buttocks areas. At the lower injuries, the spinal cord ends in kind of what we call a horse tail. That's just fancy words for horse tail. It ends in essentially a bit of a ponytail. And if you have injury somewhere along here, it injures a lot of the reflexes that can take advantage of the suppositories. And so the goal of someone who has an injury like that is just making sure they have firm, formed stool that can be passed manually with ease, and doesn't go past accidentally with bowel care routines. So again, setting up and positioning is very important like everyone else. You start and set up digital rectal stim. Digital rectal stim does not change, but the thing is, your focus is really on manual evacuation of the stool. So using one or two gloved and well lubricated fingers, you're really reaching in to help break up the stool, hook it, and pulling the stool out manually. Some patients, especially when you have injury that low, your core strength may be actually relatively much better. So they can do things like trying to push themselves, trying to bear down, breathing techniques to increase pressure in their stomach. And you can also try to tighten their abdominal muscles. So these are all things that the doctor will review with them too, but a lot of times patients may need a little reminder from the person helping them out while they're having the bowel movement to say, oh, you can try to bear down, or you can try to squeeze your abdominal muscle, you can try to massage your abdomen. Those are all techniques that they can help move the stool down when they're trying to have a bowel movement. Again, they can try to, bend and move their torsos. Really, for these guys, unfortunately, they do have to do some manual evacuation for some time, and the end is the same, where you make sure that that rectum is empty. You do a final check with the gloved and lubricated finger, and if the stool is present, you go back and you start from 4 and you come back down to 7 until you feel that you've got everything out.
Hi. You've already seen Dr. Chun's explanation of how and why we do bowel programs and why they're important for our patients. I just want to go over a few reminders of what we should expect when we are doing a bowel program. The first time a patient gets a bowel program, it must be completed by the RN or LPN so they can educate the patient on the rationale on why and how it's done. Bowel programs should be done every night. On a shower night, the bowel program is to be completed by the tech giving the shower. Unless, of course, as I just said, it's the first time a patient is receiving a bowel program. If this is the case, the RN completes the bowel program and the tech can then complete the shower. If the patient is showered with therapy earlier in the day and is not getting a shower in the evening with nursing, the tech is still to complete the bowel program. If it is not a patient's shower night, generally the patient's nurse is to complete the bowel program. If it is a light shower night, and by that I mean each tech working has 3 or less showers, bowel programs may be assigned to a tech. Techs, however, should not ever administer suppositories. Suppositories are medication and therefore should only be administered by an LPN or an RN. Bowel programs should not be done in bed. Patients need to get up to the shower chair. They evacuate their bowels more completely that way, and it's just good practice. Ultimately, it is the nurse's responsibility to make sure a bowel program is complete and reinforce the importance of the bowel program when a patient refuses. If a patient refuses, the nurse must document the refusal and that the patient was educated. It is the tech's responsibility to complete the assigned bowel programs and notify the nurse if the patient refuses. If anything is not clear in these expectations, please ask. If you have any questions at all, you can drop me an email, text me, grab me in the hallway. Please ask. Thank you.